Thank you, Emily. All right, thank you. So we're going to talk about building a successful thoracic oncology program, but also challenging the status quo. So when we talk about the problem of lung nodules and lung cancer, the first thing that we're going to have to accept is that there's a lot of lung nodules. There's actually an estimated annual incidence of 1.5 million lung nodules in the US, over 200,000 new lung cancers that are diagnosed annually. But unfortunately, a majority of the lung nodules are found at later stages. And as a result, the 5-year survival rate, unlike many of the other cancers like breast and colon cancer, the 5-year survival rate for lung cancer is less than 20%. And almost 20 to 21% of all cancer deaths are lung cancer deaths. And so when we're talking about lung cancer and the business of a successful thoracic oncology program, we have to recognize that there are multiple different components. So the way I frame this discussion is that you should talk about upstream development of a lung nodule program, which I'll go into greater detail, but it's the identification and management of lung nodules, talk a little bit about the procedures, and also the clinical and downstream impact. These are the 3 most important successful pillars for a robust thoracic oncology program. So when we talk about upstream development, the identification of lung nodules and management, I usually think of 4 things. One is an IPN program, otherwise known as an incidental pulmonary nodule lung program, a CT screening program, multidisciplinary lung tumor conference, and an electronic medical program with AI. And so let's break this down. So when we talk about an incidental pulmonary nodule program, in its basic form, it could be just radiology tagging, where a radiologist puts into the notes stating the size of the lung lesion, nodule size, etc. But in addition to that, puts into motion by stating, let's say, consider pulmonary consultation or follow up with an established pulmonary provider, clinical correlation is recommended. So if that's the case, and when the ordering physician or a follow-up physician reviews the CT scan, they're going to be initiating the next steps. Radiology tagging has a very low false positive rate, and so it's very helpful for programs that are in a nascent format to be able to identify these lung nodules. The other aspect is movement faster through the system, and it allows for a safety net for patients and allows patients to enter into clinic. And of course, it's also extremely important to be able to have navigators. When we're thinking about IPN programs, almost a ratio of 5 to 1 can find more lung nodules and lung cancer than compared to a lung cancer screening program. So that's an important ratio that came out of Ray O's paper that I think is an important aspect. So we'll talk a little bit about upstream development with regards to CT screening. So CT screening also provides early identification of lung cancer and lung lesions and these high-risk patient populations, but it has requirements, meeting ACR requirements, Medicare requirements for billing. You have to have navigators. You have to have a brick and mortar screening program where you're at all of the facilities where you're having these lung lesions identified. And then, of course, you can have a lung screening mobile CT bus. At our facility, we had the first integrated mobile lung screening bus in the country, and that's been helpful for us to grow our program as well. The other aspect of upstream development is also having a lung tumor multidisciplinary clinic, and this can account for almost half of the lung cancers that are identified. In this format, you can discuss concerning lung lesions and develop customized patient plans. And so when we're thinking about lung nodules so far, we've talked a little bit about IPN programs, CT screening programs, and the development of multidisciplinary lung tumor conference. Those are necessary, but also what is also extremely important is to talk a little bit about lung nodule management software programs. The current state is talking about NLP, which is natural language processing. NLP describes the ability of computers and artificial intelligence to identify language that's dictated and to be able to pull that information and then catch these patients. The ability to be able to read a report and say a skin nodule is not important, but a lung nodule is important for our concerns. Computational logistics is being able to interpret that language and being able to analyze that. But there are some current technology gaps that we have to face. There's a rule-based contextual analysis. And what does that mean? So there are rules that are in place. And so if you're going to install one of these software programs at my hospital or at Morningside or at Harvard or Stanford, you're going to have refinement of that analysis and those rules to be able to find those lung lesions. And so there's constant refinement for those programs at different institutions. And it could also mean that at my institution it's installed, but it could be a very different version than another hospital. One of the universal pain points whenever I talk to any hospital with a lung nodule tracking program or EMR integrated platform is manual entry. And this is when the navigator has to actually go in and manually write out tags to create the next set of steps. So typically, a lung navigator has to go through innumerable numbers of patients. They have to go back in the records. Maybe they can pull some of those records, but they have to read those, analyze them, and then tag them for future work and move that patient along. That could lead to enormous navigator workload and a patient backlog. And when you have a backlog, that's when you have some pathway confusion, and it could lead to a whole list of problems. And so there's new software that's being developed and new models. So not just NLP and computational logistics, but actually computer vision AI. What is computer vision AI? Computer vision AI means the artificial intelligence analyzes the CT scan alongside the radiologist. And large language model, or LLM, an LLM is generative AI, where you can develop reports by reading and analyzing both the image, the radiology interpretation, and also review and create dictations. And so if you take a step back, like what that means is, like, take for example, in this upper top right corner, you can see that there's an identification of a lung nodule. In this case, a widget would show up, and that's different than the current state where there are CAD programs that can read scans, but you actually have to open up a whole nother window and that leads to radiologists being reluctant because it creates a workflow that's just conflicts with efficiency. And so this type of widget setup allows the radiologist to be able to read the scan and then analyze what the widget is saying and then incorporate that information and approve it yes or no. And so the radiologist will be able to identify the lung nodule, be able to get measurements, be able to get volume, be able to compare to previous scans, and then be able to insert that into the report. The LLM dictation assistance or the generative AI can also read the report, and let's say the radiologist just forgot to take a piece of the information and the interpretation and put it down in the impression. It'll actually pull that information and then ask the radiologist to approve it there, and that allows the radiology reports to be more robust. It has two-factor lung nodule confirmation. Not only does the computer vision AI identify the lung lesions, so does the radiologist and approves it. So there's two-factor confirmation. It can also eliminate inter-reader variabilities, which means one radiologist may read a CT scan one way, and another radiologist, let's say a thoracic trained radiologist, may read it a different way. By creating standards, you can eliminate that inter-reader variabilities and lift the standard across the board. That also allows patients to have some artificial dictation enhancements. So meaning utilizing language that a radiologist may prefer, and then eliminating time, kind of just wordsmithing. One other thing that I thought was really fascinating from this company is that I saw that with chest x-rays, this type of computer vision AI can detect lung nodules that are as little as 6 millimeters on chest x-ray. And if you take a step back, there's over 70 million chest x-rays done in the United States. What if you could catch lung nodules on chest x-ray earlier? And that's the kind of opportunistic or passive screening that could really change the game for us in terms of finding lung cancer early. And then when we take a step forward and we say, okay, what else does it do? If you look to the right, you can see the way the interpretation of the deck looks like in front of a radiologist, or how it's interpreted for what the large language learning. But if you take a step back, what does that mean for the radiologist? You can get radionomic data, you can get risk stratification, you can actually assign a risk assessment to that lung nodule, and then that could trigger additional workup. You can generate tissue characterization, and ultimately what's the best part about this is that it actually reduces the radiologist's CT reading times. So they can become more efficient, they can catch lung lesions, they can compare and provide accurate measurements. They can also make sure that they have better reads, and that the reads have some conformity across the system. So taking a step back, what does this new world look like when we're talking about AI nodule management with computer vision and large language models? So just take a step back and think about this. You can have the computer vision AI read the chest x-ray, find lung nodules that might otherwise be missed, because this is ultimately a human endeavor, and not every pulmonologist is going to be able to find every lung nodule, but can detect lung nodules as small as 6 millimeters, help us find those and catch those earlier. Computer vision AI for chest CTs, providing more accurate data in terms of 3D volumes, radiomics, risk stratification, which are these lung nodules most concerning, and allow dictations to be more efficient and more productive, and allow us to make sure that there's some standards that are involved with regards to these reads. And then ultimately, this is, I think, is actually really interesting, because not only is it reading the scans, the chest x-rays and the CT scans, but it's able to allow for enhanced management, incorporating all this information. And remember, I was telling you, or telling the audience, that navigators have a difficult time often with manual tags. This type of software can read the information, create a tag, and then insert it into the workflow, minimizing some of the work that a navigator might have to do, which is, read the path report, pull that information, incorporate that. Are they EGFR1 positive? Where are they in their process? All of that can be aided and assisted with AI. So when you start to think about what that could potentially mean, we all know that if you identify lung lesions, this is the Society of Advanced Bronchoscopy, it's going to lead to higher volumes of procedures. And so we all know that bronchoscopy is better tolerated, safer, and has a high diagnostic yield, so we can avoid more invasive approaches. And ultimately, we see as programs have been developed as in ours, we see a higher volume of lung biopsy cases, and we're able to catch lung lesions earlier and treat lung cancer earlier. So the next thing that I'm going to talk just briefly about is the downstream impact. It's important to understand that if you identify these lung lesions, a lot of key role players are going to benefit. That includes interventional pulmonologists, advanced bronchoscopists, thoracic surgeons, medical onc, radiation onc. We're all there to help assist these patients. So instead of patients being caught later in the process, we can give more definitive therapies that are curative. And when we start to see robust programs, this is our hospital and CHI Memorial in Tennessee, we see a rapid increase in stage 1 and the total number of cases. And ultimately, and this is why we're all here, because this is a human endeavor to help patients, is that we can find stage 1 lung cancer earlier and decrease later stages of cancer. So the 3 pillars, just to take it back to the beginning of the talk, 3 key takeaways. You should obviously develop your upstream program. So that means incidental pulmonary nodule programs, CT screening programs, multidisciplinary lung tumor conference. Those are mandatory. But start to take a look at these new models that are involving computer vision AI and large language models for generative AI to help with reports. Not only can read chest x-rays, CT scans, but also analyze and help those navigators push those patients through. And then, of course, you want to have a procedural program that's going to benefit everyone, and a clinical and downstream impact is going to be mandatory for these types of programs. And in the center of this 3 pillars is the patient. and that's what we're bringing it to. Now, I'm going to stop now, and I'm going to introduce Dr. Zulueta. Dr. Zulueta is the Chief of Pulmonary and Critical Care Medicine at Mount Sinai Morningside Hospital in New York City. For those of you who've been to New York and actually love New York, I'm actually physically in New York right now. It's in the northeast central portion of the park, so I'll hand it off to you.
Thank you very much, Dr. Bhadra, and thank you for the introduction and for your excellent talk. I want to make sure that my screen is showing well.
Yes.
Great, thank you. So thank you to the Society for Advanced Bronchoscopy and for inviting me, and for Qure.ai for sponsoring this webinar. For a fascinating topic that I have been working on for many years. I started doing lung cancer screening with ILCAT back in the 90s, and now in New York, I've been developing incidental lung nodule program at Mount Sinai, two of the hospitals of the Mount Sinai healthcare system as pilots, with the idea of expanding to the entire system, and we're at that stage where we're ready to expand. I'm going to show you first my disclosures, if I can advance. Here are my disclosures. And this has already been mentioned as at the end of the previous talk, Dr. Bhadra mentioned, early lung cancer is a very complex problem. It's not, you can't approach it with just one aspect. It's a multifaceted approach, and very complex programs that you have to set up to do a good job. Lung cancer screening programs at the top, very important. We're doing a terrible job in implementing those. Incidental lung nodule programs, multidisciplinary lung nodule clinic, et cetera, et cetera. This has already been mentioned, but I'm going to focus mainly on the incidental lung nodule program, and I want to present, my talk is going to be a practical talk, presenting how we set up our program here at Mount Sinai Morningside, and hope that this can help you if you're thinking about doing setting up these programs. And also, we've used more conventional technologies available to us up until now, but with all these new technologies that we just heard about, we're very excited of about how this is going to change. But this is the problem we have right here, the lung nodule. And how do we get to lung nodules? The most common way of diagnosing a lung nodule or detecting one, unfortunately today, is still, and I'm talking about when the nodule is cancer, is a symptom-prompted evaluation. And unfortunately, when you do have a symptom-prompted evaluation of a lung cancer, your chances of being diagnosed at stage 1 are very low. As opposed to lung cancer screening, where if you have a cancer detected through lung cancer screening, the chances of it being in stage 1 is very high, 60 to 85%. Unfortunately, we're doing a terrible job in implementing lung cancer screening. We have to work on that. But in the meantime, what we've discovered in the past few years with work coming out precisely out of the healthcare system of Dr. Bhadra by Ray O and others, that incidental lung nodules are a very effective way of capturing stage 1 and 2 lung cancers. And many of these studies or programs have shown that they detect more stage 1 and 2 than stage 3 and 4 via the incidental nodule program. And this paper was briefly referred to by Dr. Bhadra, and it's to kind of set the problem of the lung nodule in the United States, and it is like this in the entire world. Chest CTs in any healthcare system, but at their Kaiser Permanente over the 7 years that I'm showing here, increased by 53%, while the number of members increased by only 11%, meaning that more CTs are being done year after year. And the percentage of CTs with lung nodules is also increasing from 24 to 31%, whereas the incidence of lung cancer in that period of time did not change. It's not that there are more lung nodules, it's that the radiologists are becoming more sensitive to reporting them. And this I'm talking about, almost 20 years ago. So that has increased up until today at rates probably much higher than this. In their series, 5% of individuals who have an indeterminate lung nodule or an incidental lung nodule eventually are diagnosed with lung cancer. And this is how, extrapolating this data, they came up with that figure that Dr. Bhadra already mentioned, 1.6 million new nodules in the United States every year. But this is a worldwide problem. I just showed you how in the US, the number of CT scans that have nodules has increased from 20 to 30%. In Europe, over a period of time, it had also increased from 30 to 50%. And in China, it hovers around 60% of CT scans that have lung nodules. Back a few years ago, I was working with a biotech company on a biomarker for diagnosis of lung cancer, and I did this study in collaboration with my colleague and friend Bruce Pianson from Milliman, who's an actuary company, largest healthcare actuary company in the world, and we looked at patients who have who are commercially insured in the U.S. They have access to the largest databases there are. And we looked at 1 year, 2014, how many of those had a code on their claim, a code for the diagnosis of an incidental lung nodule. We found 15,000 individuals. They had no such codes 2 years prior, therefore these were new codes. And then we followed them for 2 years, and we saw that 64% of individuals with a lung nodule received no subsequent workup. And if we go back to the Kaiser Permanente data, 5% of individuals with lung nodules may end up having cancer. We know why today most of the cancers are diagnosed in late stages. They're lost to follow-up when we have a chance of capturing them. Carrie Thompson at Mount Auburn in Boston also did a retrospective study which came up with very similar results with real-world data. Looking at their CT scans with lung nodules, they found 55% of the CT scans that had lung nodules. 27% of them had no recommendation by a radiologist, and again, only 37% of those patients with nodules had any workup subsequent to the detection. So when I arrived in Mount Sinai 5 years ago almost, we did this, and with the data that I had from the previous studies, we did this retrospective study, very small retrospective study. We looked at CT scans over a 2-month period, and we found 374 that met the criteria that we were looking for. 55% of these people who have lung nodules received no follow-up subsequently. Therefore, confirming all these data in 3 different ways that I've talked about. And interestingly, we found that, and not surprisingly, that Black patients, uninsured patients, or Medicaid patients have a much higher risk of being lost to follow-up. So with this, I was able to convince the C-suite at Mount Sinai Morningside, and I will always be grateful to them for accepting this project as an important program of the hospital. And I was given some funds to hire navigators and to to contract software using natural language processing. That's the route we went through. And this is the workflow of our program. We basically scan every single image in the radiology system of Mount Sinai, although we're limiting our program to Mount Sinai Morningside and Mount Sinai West, 2 of the hospitals. And the natural language processing looks for nodules and a recommendation by a radiologist. If those 2 criteria are met, then we get a dashboard with the number, the MRN and the CT scan report of that patient, or the imaging report. It doesn't have to be a CT scan. Chest X-rays, shoulder CT scans, MRIs, whatever. We have seen nodules come from any imaging test that includes any part of the lung. The navigators do a very quick review of the CT report, and using some criteria that I'm showing here, if there's an active cancer, false positive, stable nodules, or calcified nodules, they include or exclude patients into the program. Once they're included, they do a deeper dive into the electronic medical record, and they determine whether the nodule is incidental or not. Not being incidental means the patient had a lung cancer screening low-dose CT, or the indication for the CT was a follow-up of the nodule, things like that. And those patients are just tracked, they're registered, they're included in the program, and they're just tracked. When there's an incidental lung nodule, and those usually come from the emergency department, inpatient services, other indications that are not for lung nodules, like coronary calcium, shoulder CT, things like that. the navigators do a deeper dive into the EMR, and they determine whether there is a evaluation pathway, a diagnostic pathway established in the EMR for that patient. Is there a follow-up visit ordered, or a referral to a nodule clinic, or to a pulmonary clinic, or an oncology clinic? Or is there any indication that that patient is in the system? Then the patients are considered to be in the system, have a diagnostic pathway, and they're just tracked. They're registered and they're just tracked. For those who do not have an established pathway, we engage with the patient. And that means we call the patient directly. We tried initially calling providers, but we found that to be very complex, very complicated. And we were trying to call primary care physicians, but that's not easy. So we found a much better or effective way of doing this by calling the patient directly. Obviously, in all these other tracks, there are patients who do not complete their follow-ups, and they also come into this group of engagement. We call them to make sure to, first of all, let them know that they missed their follow-up visitor or their CT scan, and have them come back for that follow-up. So with this workflow, we have done this now. We implemented it in January of 23. So we've been going on for almost a year and a half. Here I'm showing data from a couple of abstracts that we were presenting at the American Thoracic Society in a couple of months in San Francisco, and just very high level review of some data. I can't present the details, obviously, but the first thing that we found out is that in a retrospective study from 2022, looking at incidental lung nodules found with the similar algorithms that we used in our program, we found that the follow-up rate of those nodules was 41%, again, confirming what we had found previously. And once we implemented the program, that follow-up rate had increased to 67%. Now, that's still not perfect. It's actually a little disappointing. I was hoping that we would be higher than that, although we still have many of these incomplete follow-ups pending to re-engage and to bring them back, so that those numbers will go up. And also, you know, we are a large healthcare system. We live in a city where there are many large and very advanced healthcare systems. So there's a lot of leakage of patients that go from one place to the other. So we lose those, and unfortunately, those we have to rate as lost to follow-up. And this is the results of the program up until now. And again, it's very high level, but we've included about 5,600 patients, or studies, I should say, with a lung nodule. And of these, we've categorized as needing intervention, meaning engagement, 56% of them, more or less. And of these, we've been able to engage successfully with 60%, more or less. And this is the result of this engagement with these patients. We've generated, and this goes to what Dr. Bhadra mentioned about the downstream consequences or benefits for a hospital in terms of revenues, for instance. And that applies to the United States, by the way. And in other countries, reimbursement is different, and by having more clinic visits or more bronchoscopies, hospitals don't make more money. So this is it would be a different scenario altogether. But here in the United States, every single encounter with a patient is reimbursed. So in order to justify investing money in these programs, you have to prove that there is a return on the investment. And here, look at this. I mean, with 2 years, we've generated over 1,000 outpatient visits for these patients. And here you have the number needed to include for one outpatient visit. 6 patients you need to include in order to get one outpatient visit, and 2 patients to engage to get one visit. Close to 600 CTs, 71 PETs, bronchoscopies, etc. But look at this number. This is the most dramatic number. And even though it seems low, we've diagnosed 30 non-small cell lung cancers in this group, again, of engagement, okay? 24, 80% in stage 1 or 2. So for every 76 patients we engage with, we diagnose 1 cancer in stage 1 or 2. Now, in the patients who have an established pathway and do not have to be engaged with. We've diagnosed, more cancers have been diagnosed, and look at the stage shift. It's 41% in stage 1 and 2. We still don't know exactly the reasons for this big difference. I have a hypothesis that I can leave for the questions maybe, but it's very interesting. And I think, now I'm going to try to compare this to data from other centers, and I think it makes sense. This is the paper that Dr. Bhadra mentioned, and I'm going to refer to because I think this paper is a game changer. It's from Ray Osari-Agban, or Ray O, as we all know him, from the Baptist Memorial Healthcare Corporation. It's one of the largest healthcare systems in the country, covering 111 counties with the highest incidence of lung cancer. And basically, in 2015, they set up 2 programs, the lung cancer screening program and the incidental lung nodule program. And they have followed these in parallel since then. And here they presented in this paper, which was published in 2022, the results of 7 years of the program, the first 7 years. Look at the number of patients screened and diagnosed with cancer in the lung cancer screening. 3% of the screenees were diagnosed, 156 cancers. And Dr. Bhadra mentioned this, 5 times more cancers diagnosed in the incidental lung nodule program. And this is the same system in parallel. So this is real world data. And this is the most amazing figure here, 60% in both groups diagnosed in stage 1 and 2. Proven again that the incidental lung nodule program is a great chance, it provides a great chance to the system to capture patients who already are in the system. They have their image there, but they're at risk of being lost to follow-up. And by doing these, by setting up these programs, you capture these stage 1 and 2 diseases, just like you do with the lung cancer screening. In their multidisciplinary tumor board, they obviously diagnose many more cancers. The rates of stage 1 and 2 are lower, although pretty good, 44% compared to other series. But clearly, this is a great opportunity, and it proves that it works. And going back to our data, just to compare it to Ray O's data, if we combine both groups, the engaged and non-engaged, we get about a 51% rate of stage 1 or 2, which I think is similar to, you could say it's similar to the 60% that they find. Obviously, our numbers are much lower. We're only presenting here 26 months of data. They're presenting their 7 years, and it's a much larger healthcare system too. But I think that this is promising. And what I want to point out here is that we're showing a unique workflow here by engaging with just some patients, not all of them. If they already have a workup plan, we do not call them, and we don't have to. And the reason why is because this is really FTE intensive. We have 3 people, 2 coordinators, 2 navigators, and a physician assistant working full time on this program, and that takes up a lot of resources and a lot of time. So I think that what we're going to talk about now is how to reduce that need for the human interactions and manual work to make these programs much more efficient. So just to summarize what I've said up to now is that incidental lung nodule programs work, and using natural language processing works. You need the navigators, you need the advanced providers. It effectively identifies patients who are at risk for not undergoing evaluation, and you detect patients in early stage. So that is all great, and what we heard from the talk before, this is just everybody benefits from this, and we're going to be doing more nodules, and we're going to be seeing many more patients in all of our services. However, let's not forget that all these interventions have risks. Any diagnostic procedure, process in any aspect of medicine has its risks. And these are the 2 main ones. If you have a low sensitivity, or said with other words, high false negative rate, you're going to miss patients with a potentially treatable condition. And if you have a low specificity, high false positives, you're going to do excessive diagnostic tests. In this scenario of lung nodules, those diagnostic tests may be invasive, bronchoscopies, IR biopsies, etc. Excessive treatments, which may be surgery, anxiety for patients, and costs. We have to take this into account whenever we deal with new diagnostic programs. And just to show it graphically, what the ideal situation would be is that, we have a population here of people who have had a CT scan. And in that population, we have people without any nodules, people with a lung nodule that does not need follow-up here in purple, people who have a lung nodule that does need some sort of diagnosis because they're suspicious in black, and then lung cancer. Now we apply a test or a list of tests or processes, and we separate all the suspicious and cancer patients from all the normal and no need for workup patients. That is perfect. And now we apply a second test to the top group here, and we separate the patients with lung cancer from those who are only suspicious but do not have cancer. Here we have an ideal situation. False negative rate of 0, false positive rate of 0, sensitivity 100%, specificity of 100%. Obviously, this doesn't exist. So we have to balance this. And when you balance diagnostic procedures, you can aim for a higher sensitivity. Usually what happens is that you sacrifice specificity. Less false negatives, you're going to have more false positives, and vice versa. So you have to be very careful. And with AI coming in, AI developers have to be careful and have to be thinking about these situations. The reality is that we do have false positives in both situations, and we do have false negatives in both situations. And sensitivity and specificity are not 100%. So how can the AI help us in all this scenario, taking into account those risks? So in test number 1, which we can divide into several processes, number 1 is the image acquisition. We already, this is already in most commercial CT scanners, personalized protocol selection, AI-driven dose prediction, real-time parameter adjustment. As the CT scan is being done, the dose is adjusted to the scenarios according to AI algorithms. That already exists. Then comes, and I'm not going to spend much time here because Dr. Bhadra already mentioned this very, very clearly, radiologist interpretation and the use of NLP in our case. Well, AI here is going to be very, very important. We already have products out there that can do diagnosis, they do detection, CAD-E, and there are some good data coming out showing that diagnosis can also be done. And Dr. Bhadra mentioned this. NLP, is NLP obsolete? I don't think so. And probably NLP combined with more advanced AI technologies is going to be the way to go. And again, Chris mentioned this as a possibility. And then there's once we get the dashboard and we have to make decisions, take some actions, call the providers. Here is where I think right now traditional AI is important, but generative AI is going to start coming into play, and it's going to really have an impact. And let me just show you our workflow again with some very basic numbers in terms of time dedicated to each step. For the first inclusion-exclusion step, the navigator spent about 2 minutes per case. For the second slightly deeper dive into the EMR, the navigator spent about 7 minutes per case. And for the rest, engagement, classification, following, tracking, the navigator spent some time, but with the engagement only, the physician assistant of our program, Sasha Adler, I want to shout out to her because she does an extremely good job, takes 2 to 15 minutes per case. So AI here, you can see, can intervene in many different steps. For instance, in the first step, this extraction of data and include and exclude, that can be automated easily, I'm sure, by AI. Even this deeper dive into the EMR and extracting data to classify patients into non-incidental, incidental, no established pathway, there is an established pathway, all that can be automated by AI. And even engagement maybe. However, this is something that maybe we can discuss later. Are patients going to be accepting AI bots calling them or communicating with them about a lung nodule? I today see that difficult, but maybe with the providers, it's going to be easier to do it that way. Right now, for us to call providers was complicated, but maybe with communication through the EMR, through Epic Chats, et cetera, that might be something that will take a lot of time away from our navigators and the lung nodule program. In the second part of the testing, the diagnostic part, once we have the lung nodule already, we use guidelines today, and the guidelines, you know how they are. If you have risk factors, you have to follow up in 6 to 12 months. If you don't have risk factors, you can follow up between 6 and 12 months. Very, not very clear. And usually we end up discussing these cases in our tumor nodule board. And you know how those discussions go. They're not mathematical. There are a lot of gray zones and a lot of opinions. AI here, I think, is going to play a very important role in gathering all the data. Generative AI can bring data in from different sources and help summarize the discussions and come up with automate registry maintenance, et cetera, and even once the decision is made, to generate appointments and automate admin processes. But I think, again, AI is going to be very important here. And then the more diagnostic part, the interventional pulmonology or interventional radiology, and then pathology, obviously AI is going to play a role. I'm not going to go into this in detail, but you can imagine with the amount of information that comes out of these tests, AI is going to have the capacity of mining all this information and bringing it together for automatic staging, including genomic analysis, biomarkers, et cetera. And this is a little wish list that I added for lung cancer screening, which has been my passion for over 25 years. Eligibility risk assessment. The eligibility criteria today for AI, for lung cancer screening, is horrendous. 50% of individuals with lung cancer cannot undergo screening. They're not eligible for screening. 50%. That is terrible. Can you imagine the situation? Everybody has a baseline CT scan. And now use the information on that baseline CT scan to determine your risk and your need for screening subsequently. And you can add into that your smoking history, your family history, but AI can extract so much information from that CT scan. The presence of emphysema, we published a paper, we were the first to publish, that if you have emphysema on your CT scan that you can visually see, your risk of lung cancer increases threefold. AI can probably detect that even more sophisticated, in a more sophisticated way than we could. Diagnosis of nodules at time 0, CAT-X. Right now, we have to follow up nodules 6 to 12 months later. So imagine having the diagnosis right at the moment of detecting that nodule and reduce that need for follow-up. That would be huge. And then other incidental findings. I mentioned emphysema, but there's coronary calcium, there's heart chambers. There's already work out there, one of the companies that I advised, showing that in the lung cancer screening CT, AI can measure heart chamber sizes and predict the occurrence of AFib or other cardiovascular events in the future. So we're really into some very exciting times coming on, and I'm very happy to be involved in this right now because it's going to be a lot of fun. And I don't want to finish without this shout out to Michael Gieske. He runs a lung cancer screening program and an incidental lung nodule program at the St. Elizabeth Healthcare System in Kentucky. And first of all, he's an incredible guy, but I was really impressed with this data that he presented at the last World Conference for Lung Cancer. He started both programs as his lung nodule early detection program back in 2015. And you can see in blue how this early stage cancer percentage has been increasing. And up until 2022, when it equaled the amount of early stage cancers and late stage cancers that were diagnosed in the system. And in 2023, for the first time, I think probably for the first time in any healthcare system in the world, they diagnose more early stage lung cancers than late stage lung cancers. And that is using, 2015 technology. So with what's coming, this is going to be it should be reproduced in all centers around the world. And I think it is going to happen, and it's very exciting to be part of this. Again, a big shout out to my team. I'm very, very grateful to all their great work, and I'll stop here. Thank you.
Wow, that was absolutely fantastic. Dr. Zulueta, I've actually learned a lot just listening to you talk about this and your experience and all of the things that you've done with regards to the development of lung nodule programs and actually studying them and these new innovative ideas. We have a couple of questions from the audience that I wanted to ask. The first question that came was early on during your talk, is that you were talking about levels of engagement and utilizing FTEs. It's a two-part question. One is you have thousands of lung patients with lung nodules in your program. You currently have 3 full-time employees or navigators that are helping you. With regards to scaling, is there a proportion that you would think would be appropriate? And then the last piece is that, do you think the AI technology could take over some of those tasks and that patients would then interact with bots? And how would that be perceived? Is that what you're thinking?
Yes, I mean, I think we're at a stage where we have a great opportunity ahead of us, and that's the use of AI to take over a lot of the admin process here. But not only the admin process, to help classify the patients. If you can take away those 10 first minutes in the flow that the navigators have to dedicate to each case, that's a lot of time. And then the communication with the patients, that's one of the trickiest aspects. I don't know how that's going to pan out. Right now, today, as a physician, we've had problems sometimes with us communicating patients who we don't know, to call them and tell them, hey, you have a lung nodule. It's not an easy scenario. So I don't know how we're going to work that out. I think it's probably going to be much easier in that situation, to start contacting again with the providers, with the primary care physicians, have bots communicate with them directly.
Yeah, what I think is really interesting is that I've been in the lung nodule business for a long period of time, but actually seeing Rayo's paper, seeing your paper, you're really changing the landscape of the way lung nodule programs are really being developed. There's a question from one of the audience members. It was asking, do you think that all programs across the United States, as let's say you graduate from an interventional pulmonology program, or you're an advanced bronchoscopist extremely passionate about diagnostics, right away, should you start looking at these computer AI vision and LLM generative AI models? I mean, is this something that we need to really investigate on the front end, or do you wait a few years, or do you have that conversation?
I would start that conversation yesterday.
Okay.
First
so
of all,
these new fellows, these new employees, just put it out there right away and say, hey, and then how do you present this to the C-suite when you think about this? Because there's a lot of different variables. There's, obviously IT, there's personnel, it's the program, it's the software installation. How would you recommend to somebody who is a brand new graduate or really investing or looking at this talk? Because when I heard your talk, it made me actually think, our program is not as robust as it could be. There's a lot that we can do to make it better. And what would you tell somebody like to get started?
The key for the C-suite obviously is they don't want to lose money. I mean, we're physicians and we're interested in one thing, which is taking care of patients and curing cancer. But the C-suite has to look after the health of the system, obviously. And if they start investing in programs that are losing money, then nothing's going to work. So the key here is the return on investment. And in the United States, again, this doesn't apply for those of you who are listening from outside the United States, it's different. But in the United States, encounters with patients, all procedures, all tests are reimbursed. So, and we're going to, hopefully we're going to be publishing some economics on our program soon. With all those tests that I showed that are generated, you do generate a positive return. So even though we have an intense dedication of people and FTEs, the return on investment is positive. There is a net gain here. So it's definitely justifiable. Of course, you have to be able to convince, I was able to convince my C-suite with the literature because I didn't have our own data. But
I was
now there,
just take your paper and walk over to the C-suite. But I do
well,
think that's important, because what you're talking about is you have to recognize the financial aspect. You can't have a failing program. But this is almost like one of these unique circumstances. You can widen the net for lung nodule detection. So you have more lung lesions that are being identified, followed, tracked, and treated appropriately through pathways that will obviously evolve and grow. But you have patients that are going to be detected earlier. You've got real financial benefit to the system because they're going to get downstream. Clinicians will be able to treat these patients earlier for curative intent. And it's basically the perfect story. You invest in this kind of software, and then you'll have better patient outcomes. Would you agree?
I have no doubt. And I would, to expand a little bit on this to the outside of the United States where reimbursement is different, you can, the argument is also positive because you're going to be stage shifting patients into early stage disease, which is not as costly to treat as late stage disease. So in countries where there's public health systems, there's also a benefit, clear benefit. First of all, because your citizens are going to be treated correctly and cured of one of the worst epidemics in the history of the world, which is lung cancer. But also, you're going to be saving money for treatments of late stage cancer.
And what do you think about Qure.ai's endeavor to look at, so one of the things that I thought was just unique about the computer vision is that, we've all heard of programs that look at CT scans, obviously, but then looking at chest x-rays, and I wasn't aware of anything like that. Do you think that that's going to be valuable? Because for me, I think chest x-rays is one of the bigger medical legal aspects where things are missed. They're not as obvious. And I almost reflexively order CT scans because I'm really trying to identify lung lesions, masses, pleural effusions, which is my wheelhouse in interventional pulmonology. Do you think across the system something like this, like set up passively, will be beneficial? Obviously, it needs to be observed very carefully, but that there is some potential benefit there.
Listen, if you look at the NLST data on the chest X-ray arm of the trial, 35% of the cancers were diagnosed in stage 1 or 2, or stage 1. That's a very high rate compared to other series. Chest X-ray detects cancer early, and the reason why the NLST, the chest X-ray, did not show, I mean, it was compared to low dose CT, so it can't show any improvement on mortality, but it is detecting lung cancer, and chest X-ray is done, an order of magnitude more than CT scans in the United States. Around the world, you can't even imagine. So yes, there is I think it's a very important, it's very important to keep in mind that chest X-rays is another source of capturing individuals with early stage lung cancer.
I got another question. This one was for me. This is a simple answer, but there was a question. Some people are aware of Viz.ai with regards to stroke protocol. They were wondering if the platform looks similar to that. I think it's the same idea. Viz.ai is a computer vision for looking at head CTs and then early detection of lung cancer. I live in a city where it's one of the stroke capitals of the US. Yeah, and we actually use Viz.ai. This is a very similar idea, but applied for chest x-rays and CT scans. I think with regards to where do you see us going in 5 to 10 years from now with regards to lung nodule management programs? Because right now, I don't think people really have taken, or so for someone like me who's read Rayo's paper, read your paper, I look up to you and I say, okay, these guys have figured it out, right? Where do you see us in 5 to 10 years? Stage shifting occurring kind of universally across the system, or do you think that these are going to really take off? I just want to kind of get a sense as to, because there is some reluctance from some people saying, AI medicine, what does that look like? What do you think?
I think to be reluctant, I mean, you could be reluctant, but it's going to go right over you. I mean, I think AI AI is coming at such with such force that it's going to happen, no doubt. Now, there are a lot of issues regarding healthcare, no doubt about that. AI is as good as the data that it used to get trained on, right? So there's many examples out there that if you train an LLM on a biased cohort, you're going to get biased results. So that is very important. And that's going to have to be worked out, but it is being worked out. And I think that AI, in the way that companies like Qure and other companies are working on, it's really going to help solve a lot of problems and help us be a lot more efficient in our work. If you think about it, our day-to-day in the clinic is not efficient at all. The time we have to spend typing on a computer, looking for orders, looking for that, even those basic tasks can be taken over by AI. So I think we all should be ready for it, and we all should learn about it because it's coming. And I don't know if you heard Bill Gates say the other day that in 10 years, physicians aren't going to be needed. I think that would be
out of a job, according to Bill Gates. That was like, but I do think that human interaction will obviously be part of this. And I don't know if all physicians are going to be gone. He did say that coders will be around, so Qure will still be around. So that being said, from an AI perspective, there was a question about engagement. When you say engagement, does that mean the telephone call, the office visit? What do you define engagement as?
Yeah, sorry, I did not define it clearly. It is the initial call, the contacting the patient.
Okay.
Not all of those patients actually come to the clinic. We have some criteria. If it's larger than 6 millimeters, we recommend a lung nodule clinic. If not, we just recommend, hey, follow up with your PCP. You have a chest CT. The recommendation is that you should have another one in 12 months, things like that. That's the engagement, that initial communication.
Gotcha. Any other closing thoughts? I learned a lot from you. I think this was really eye-opening for me. And I think that as an interventional pulmonologist and a real believer in advanced bronchoscopy, I think we need to have guys like you and individuals who have studied this, the experts, kind of out and come in front of our field, because we're all trying to build it in similar fashion, but it almost feels like you're 200 mistakes ahead of everybody. And so you've kind of figured out what the formula is. And, do you think that we should start incorporating this into the fellowship programs and the residency programs? This is how you build a lung nodule program. These at least are the things that we agree on and you should implement.
Yeah, I do think so. I mean, we're really starting a new era of treatment of or approaching lung cancer. I mean, when I trained much earlier than you did. When I trained, it was a death sentence. There was nothing to do. But now, with all these different tools, lung cancer screening, we have to do a better job there. Incidental lung nodules, that is an amazing tool that we have in our right in front of us. That's changing the field of lung cancer. We're going to be curing more lung cancers than not. So I really do think that we have to get our fellows involved. We have to get everybody involved as soon as possible.
Gotcha. And then with the training of these AI models, what do you suggest that we, as let's say we're a consumer, what are the questions that we should be asking some of these software companies with regards to their algorithms and their programs? What are the things that you think of? You've already done this. You've already seen it work. If you could go back in time and tell somebody, okay, hey, you're in the market for looking at some of these programs. These are the questions that you see if this is a fit for you.
Yeah, I really think that companies like Qure.ai and others that are developing all these protocols have to be very transparent in how their algorithms have been tested, trained, and how they should talk about the biases that do exist, no doubt, because people are going to, right now we're not educated on this, but people are going to be very educated, and there are some examples of disasters occurring in healthcare with AI. Of wrong diagnosis with the same scenario, but the patient is black or white, you get a different diagnosis from the AI. Those things happen. So I think we have to be careful. I think the companies are doing a good job in training the algorithms with well curated databases. We have an LST for lung cancer screening. We have others. So, but yeah, I mean, as long as that data is published and it's transparent, I think we're going to be able to explain this correctly to the patients.
Well, on that note, that's why they call you the expert. That's a really good answer, talking about the transparency, talking about the databases that they use, and that we recognize that, you know, with any kind of endeavor that we do, both in medicine, both procedures, whether it's these algorithms that are being developed from an AI standpoint, they're going to have some level of bias, and so we have to recognize that. And so thanks a lot for joining us with the SAB. I actually learned a lot. This was fantastic. I don't know if anybody noticed, but there was a QR code. You can contact us directly, and I'll hand it over to you, Emily, to close this out.
Yeah, no, thank you both. It was an excellent presentation, very informative. And if anyone does have questions, here's the QR code. You can reach out directly to Josh so he can get other questions answered. And I want to thank Qure.ai for sponsoring this webinar event, and we appreciate you all joining, and have a wonderful evening. Thank you.
Thanks, guys.
Thank you.